Welcome and good afternoon and good evening to those of you on the East Coast. Welcome to the 6th Annual Touro University, California Social Justice and Public Health Speaker Series hosted by the Public Health Program. My name is Gail Cummings and I am the Program Director for the Public Health Program here at TUC, and I will be moderating today's session along with Professor Deirdre Wilson. This year's series, entitled Public Health in Times of Pandemics, will focus on two public health crises, COVID-19 and the impact of police violence, both of which have collided into a devastating pandemic tandem, and both which have disproportionately impacted Black, Indigenous, and other peoples of color. To help us understand and untangle the root causes, implications, intersections, and solutions of these two public health crises, today's talk is the third in our six-part series. This series was launched earlier this fall with Deputy U.S. Surgeon General Dr. Erica Swartz and Dr. Vin Gupta, who spoke specifically about the clinical impacts of COVID-19. Our second talk was led by Dr. Tony Eiton, who talked about the root causes of health inequities and the political framework and narratives for addressing health and health care from an upstream approach using what he termed the social contract. Today, we're very excited about our presentation, Impacts of COVID-19 on Black, Indigenous, and People of Color, which is a natural follow-up to Dr. Eiton's talk and will feature Dr. Shandi Miller, who is the Solano County Deputy Health Officer, and Dr. Susan Rogers, who is a volunteer attending hospitalist and internist at John Strober Junior Hospital in Chicago, and is also an assistant professor at Rush University. Before we begin with today's session, I would like to proceed with a land acknowledgement statement. And for those of you who are new to this series, we provide a land acknowledgement statement at the beginning of each of our programs. And although we're meeting virtually, we still think it's important to repeat, even if you've heard it before, because we think that it also recognizes that the land itself is not just the space that bodies occupy, it is also a depository of culture, story, history, and tradition. It's also an important way and allows for an expression of our gratitude and appreciation, as well as a way to honor and really understand the history of specific tribal nations. Our statement is as follows. We want to acknowledge that Touro University, California is a site on the traditional land of the coastal Miwoks, the Susunis, and other Patwin peoples, past, present, and honor with gratitude the land itself and the people who have stewarded the land throughout the generations. This calls us to commit to continuing to learn how to be better stewards of the lands we inhabit as well. Thank you. Now I'd like to turn it over to Professor Deirdre Wilson, Chair of the Community Health for Action Concentration.
Hello, everyone. Hopefully you can hear me now. And welcome to our session this evening. I have a few things that I'd like to cover. For those of you, we are in Zoom and we have a recording policy. We are making this recording available to those who would like to view it in the future and also for continuing education units. This is also a required course in the Masters in Public Health program, and attendance is required, and completion of the speaker evaluations after each session is required. There will be two presentations this evening, as Dr. Cummings mentioned. The first will be by Dr. Susan Rogers, and the second by Dr. Shandi Fuller. A Q&A session will follow after both presentations. You may submit questions by using the Q&A function in Zoom. CME credits are available for this session. You may go to also for CPH, the National Board of Public Health Examiners, to also receive credits if you have a certified in public health credential. The continuing education information statement is as follows. I'll briefly let you take a look and then provide the link. The link will also be provided in the chat function. So for CME credits, please go to www.eeds.com and submit the activity code 15ARTS. Thank you. Now I would like to go ahead and introduce our speakers. This evening, the first speaker is Dr. Susan Rogers. Dr. Rogers is currently retired and is a volunteer attending hospitalist and internist at the John H. Stroger Jr. Hospital, previously known as the Cook County Hospital in Chicago, Illinois. She was a director of medical students programs for the Department of Medicine at Stroger Hospital and remains an assistant professor of medicine at Rush University. After Dr. Rogers speaks, we will also welcome Dr. Shandi Fuller, who, as Dr. Cummings mentioned, is the Solano County Deputy Health Officer who advocates and administers equitable care so that all children and families live to their greatest potential. As a pediatrician, Dr. Fuller is the co-facilitator of Solano Hills Health Equity for African American Black Lives and promotes equity and healthy births for Black babies and their families in Solano County. Please join me in welcoming Dr. Rogers as she begins her talk.
Thank you so much, Dr. Wilson. And let me get my slides shared here. Now, I did this before. Can you see my slides?
Not yet. We see your home screen. Oh, there you are. Great. And just
okay. Now I'm ready.
View.
Okay. All right. Okay. Thank you so much for inviting me to be a part of this. This is really, I think, exciting. And I think that it's so important that these things are being discussed and talked about. And I think that there's a lot that we all need to learn. And what I want to talk about is why we have health inequities, because I think that this country does not teach its history. And I learned a lot just by looking into things for this talk. You kind of know this and that, but it was hard to put it all together. So it really cemented all the details so that it made sense to me. And one of the things that is important to understand is that it isn't race that causes these inequities, it is racism. There's nothing innate about Black people, about Asian people, about Latinx. It is racism that creates the inequities I see, and that they've been further brought out by COVID. And I will show you some data that will explain that. But let's make sure that we're clear on some definitions. And we use the term disparities in this country a lot. And I don't like that term myself because it just sort of means that there's a difference. It doesn't give you any indication of why, whether there should be a difference or what it means. But the term health inequities does imply that. It means that there is something inequitable about it. It's unnecessary, it's unfair. And the fact that it is unequal means that it could be fixed. It doesn't need to be there. And interestingly, the WHO, the World Health Organization, uses the terms inequities, but the United States prefers not to, and we'll see why. But let's get into a little history. And we all know about, after slavery ended, and then we went into Reconstruction, and after Reconstruction ended in the late 1800s, Jim Crow, which was always still there, and the Black codes and all of the criminalization of Black behavior and convict leasing, all of that really kept the society of slaves and slave owners intact, especially in the South. And so things were very, unsettled. Well, they still are. But up until the New Deal, nothing was done to address anything. But the New Deal, which is touted as this, saved America, really did not help Black people. And one of the things I do want to make sure we understand too is that when we use the word race, race is a social construct. There is nothing scientific about race. The Human Genome Project showed that we are all 99.9% the same. There's some ethnic differences. There's some genetic mutations that are different that have fallen down ethnic lines. And a lot of that is related to geography, to religion, the way people used to live. But there's nothing about race that you can identify scientifically. It is totally social, and it was made to define who could be a slave and who could be a slave owner. And what that did too was that it confirmed in this society who was superior and who was inferior. And that relationship has not changed since then. So let's talk about what FDR did with the New Deal. And what he did was, after this started in the early 30s, and it was to help build up the economy after World War I and the Great Depression after the stock market crash. And it was to help build the economy back up. There was a lot of unemployment, and he was actually addressing the issues that white people faced during this time. So when he came up with Social Security, what he did was he defined employment in a way that it disenfranchised Black farmers, who made up the majority of Black men in the South. It disenfranchised domestics, and that's what Black women used to do. And it also disenfranchise anyone who was self-employed, so anyone who had a small business, which a lot of Black people did, especially in the South. So they were not able to benefit from any of the benefits of Social Security. There was unemployment, not just benefits after you got to be 65, but the unemployment, victims for accidents, people who were disabled, all of that. There was no way that we could benefit for that. That all went to almost all white people. And then there was the Aid to Dependent Children and Families. When I was growing up, it was called ADC. It wasn't called welfare, but I was born in the 50s. I'll admit it, I'm old. But what it was a benefit to help white women who had children. It was not felt to be an entitlement at all. It was to help them because some of them did not have husbands, some of them were illegitimate children, but it was there to help them. And it wasn't until the 1990s that this expanded to include Black women. That was when it became an entitlement. That was when it became money from the government to help people who didn't want to work. So this was, presented in a way that it made Black women look like they were freeloading off the government, where that was exactly the opposite of what they were doing when white women received the benefit. The farmers, the Farm Security Administration, what happened in the South after slavery ended and most of Black people lived in the South? Everyone was free at that point, but slaves had nothing. They were not able to learn to read and write. They had no legal protection, but many of them were sharecroppers, and it was not a system where they could ever get out of debt with the white landowner. And so what happened was that over the years, they essentially stole the farmers' land. They had no legal recourse. They couldn't act, with the bank at all, so that they were just victims. They were all victimized, and over a period of time, the land was just taken. And then even in the 80s, when there was the big farm crisis, and that was when prices for crops were really low, and the farmland had fallen. It was much cheap. And so there were all these benefits that were given to farmers in the South so that they would not lose their land. And so the USDA, what they did was they came up with over $1 billion benefit that was given to 16,000 farmers in the South. And out of all those farmers, only 209 were Black. So none of these governmental benefits were meant to help Black people. A few did, but that was not who it was for. Black people have been disenfranchised from everything. The other thing that happened with the New Deal was the Wagner Act. And what this was it formed the National Labor Relations Act. And what it did is it authorized unions to be able to lobby and as a group, try to work for increased benefits, wages, and all of that. But it did not prevent unions from keeping Blacks out of the union. So what happened here was that, especially during this time, the unions became very powerful. Those were where craftsmen got great jobs because they were able to strike and lobby for good wages. And Blacks were never able to be a part of this. And even today, the unions are often very segregated and Blacks aren't allowed to be part of that. Some do, but as a whole, they could not benefit from all the advantages of being a union worker during that time. Now, the other thing that the New Deal did was it created the Federal Housing Administration so that they could provide government-secured mortgages after World War I, and then the government started subsidizing contractors to build homes. And it was very clear that they were building homes for white people. And there were what they called redlining and restricted covenants, where if there was a Black person living in a community or a neighborhood, you could not get a mortgage within that community, which prevented Black people from ever moving into these suburbs that were built by the government for white people. And so this was how segregation became it was government sanctioned and funded. And so this didn't happen by accident. In fact, no racial inequities and disparities happen by accident. They're created. And so what happened is that the communities where Black people were forced to live were never supported with government resources. They had poor sanitation, and poor communities have poor schools. So it became difficult to get out of that. There was nowhere else to go. And there were restrictive covenants where white communities said they could never sell to a Black person. There were contract mortgages, so that even when Black people tried to buy into a red line district, these were predatory loans where they never had any ownership into the home until they paid the last payment. So it was like renting, although you acted like an owner in the sense that you had to fix everything with the house, even though you didn't own the property. And the rates for these mortgages were very high. These were predatory loans, similar to what just happened in the 2000s. All these predatory loans done by banks that preyed on minorities who could well have gotten a regular loan. Their credit was good enough, but they were steered into these subprime mortgages because the banks could make more money. And so this hadn't changed. This whole idea of preying on minorities and people who may not have the relationships with banks well enough to navigate itself. And I don't know, getting a mortgage is difficult. And I have never read all 25 pages of my mortgage. And so it's a very overwhelming thing. And so they were just taken advantage of. And even now, there's exclusionary zoning, which prevents affordable housing being built in wealthier communities. So the segregation, it was created actively. It did not just happen. And it is actually the root of, I think, of all the racial issues, the the racism and all that we have, because we're all divided. There's no interaction. And so it allows myths and stereotypes to perpetuate. And one of the things is that of all the home ownership loans that were approved by the government for over 30 years, whites received 98% of these mortgages. And then there was the GI Bill that came out, and this was to support the GIs that came home after World War II, and this was federally funded, but the state administered it, so the state decided who got what, similar to the way Medicaid is now. It's a federally funded but state delivered benefit. But out of all the home loans that the GI provided, less than 100 out of 67,000 home loans went to Black GIs. And only 2 of the VA loans went to Black GIs. The training facilities for the GIs to get new skills or, improve on something that they had learned in the war, those facilities were segregated in the South and often still segregated in the North too. So they were unavailable to Blacks. Colleges in the South did not admit Blacks. The historically Black colleges did, but they were often overloaded, they were under-resourced, and they weren't always necessarily a resource or a school that they could go to because they were just so overwhelmed. The Tuskegee Airmen were not allowed to become commercial pilots. And my father, who went to Italy in World War II, when he came back home to Macon, Georgia, he still had to sit in the back of the bus. So what these programs did is they created a white middle class that Blacks could not be a part of. And this whole idea of if you work hard, you will achieve, this shows that is not true. Working hard did not necessarily get you anywhere when all of these government programs and fundings went elsewhere. They all went to white people. And I'll show you later how this has created the wealth gap you see now and all the other issues that come with continued segregation. And this was when healthcare actually was desegregated, not until 1965 with the Civil Rights Act. And this was when Medicare and Medicaid were created by Lyndon Johnson. And what he said was that if the hospitals are going to get federal money, then they have to desegregate. And this is what prompted that. It took a long time for all hospitals to do that. And interestingly now, hospitals don't have signs that say whites only, Blacks only, or, you have to use a certain door to go in. But they segregate by insurance. And this is why I support a Medicare for all single payer system, because right now, if you don't have insurance, you can't get things done. You can go to the emergency room because by law, they have to see you. But if you go to the emergency room and you have abdominal pain and they find out you have gallstones, for example, they'll just tell you, well, you have to go somewhere to get them taken out because we're not going to do that. That's not the emergency. And so we have another way of desegregating healthcare institutions, and that's by the payer. And if you have Medicaid or Medicare, you have fewer choices because not all physicians will take that. And those are the hospitals, too, that often get into trouble financially because Medicare and Medicaid do not cover their costs. And for hospitals to do really well, they need a majority of private insurance payers. So segregation became illegal racially back in the 60s, but it still did not necessarily provide equal care. And so what all of this segregation has done is it has created areas of what we call concentrated poverty. And concentrated poverty is where more than 30% of the people living in that area live below the federal poverty line. And the federal poverty line was just established back in the 60s with Social Security, and it's a minimum amount of money that a family or a person, depending upon the household size, needs to live on for 4 weeks. It was never intended, well, maybe it was, but it wasn't meant to be what you can live on indefinitely. It was an amount of money to cover emergencies, to cover things like food and clothing and housing, your basic essentials. It was not made for you to live on for your life. And so we've got areas now of concentrated poverty, and they are mostly Black. And that's because whites can live wherever they want. More well-to-do communities will tolerate poor white people, but they will not tolerate poor Black people. And that's because of segregation, which perpetuates the myths and the stereotypes that created the existence of segregation in the first place. It's a vicious cycle. And so this is why you don't see white ghettos. But if you look at Chicago, for example, where I am, 35% of poor Black people live in areas of concentrated poverty, whereas there's less than 5% of white people do. So white poverty is very different from Black poverty. And that's why white people can still grow up poor. They can still grow up with some disadvantages, but they live in neighborhoods that provide more services. They may have access to better schools. They have access to better food. They live in a safer environment. So growing up poor and white is not the same as growing up poor and Black. And so what this has done is led to a really disparate wealth gap. And what you can see here, and this is the graph on the left is for Blacks, and the graph on the right is for whites, is for Hispanics, which needs to be changed since we don't use that term anymore, or at least we shouldn't. But what it shows is that for Blacks, whites have 10 times the amount of wealth. And wealth is actually more important than income, because you can have an income that you can live off well, but you have no safety net if you have no wealth. And by having wealth, you can incur, when something comes up, you have assets to take care of that. You, as time goes on, and your children grow, you can help them. You may be able to help them pay for college. You can do whatever, but your children can benefit from your wealth. But if we don't have that, we're lost. And so we often crumble, or we really struggle when things come up because we don't have those assets, whereas whites do. And this is a reflection of having home ownership, which is the way this country, most people build wealth. We're not talking about the 1%, but most people get their wealth from home ownership, and Blacks were totally shut out of that opportunity. And so what happens in cities where they are segregated and you have these differences, this is a picture from Chicago, and this is from the Robert Wood Johnson Foundation, but they've got these maps for a lot of different cities. And this is just the public transit as part of it in Chicago. But what you can see, if you look at the green on the left of the graph, as you go from the left towards the right, which is into downtown, which is the wealthier, the financial, the business part of the city. It's on the lakefront. It's where you have all these luxury condos and high-rises and all of that. Your life expectancy increases as you go closer to downtown and decreases as you leave downtown. And this is in all directions. And the south side and the west side is where most poor Black people live. And also in these communities, there's people who are not necessarily poor, but they are not welcome in other white communities. So you've got this health gap that was created. This didn't just happen. It's not because people in East Garfield Park don't want to eat right, or they don't want to take their medicine, or they don't want to go to the doctor. This segregated community, it was created like this, and this is what happens. And there's actually communities in Chicago where the life expectancy gap is up to 30 years between the lowest and the highest. And so the unemployment gap that creates, Black people have always been more unemployed. Their unemployment rate has been higher, always. Not just now with the pandemic, but it's always been higher than whites. And so this has even been made worse with the pandemic. So why are people of color getting sick more from COVID? And it's because they're more exposed and less protected. It has nothing to do with their genes. It has nothing to do with their race. Well, it does have something to do with their race, but it's because of racism. There is nothing innately about Black people that make them more likely to get infected and become more ill because of COVID. But once they are infected, they are more likely to die because they have a greater burden of chronic diseases and they are living in poor neighborhoods that don't support their health. It's a lot of reason they have jobs that create an environment where they are more likely to get infected. And so this has been created. This didn't just happen. Believe me, nobody chooses to live in substandard housing in a community that has no resources. There's a reason why people are stuck there. And poverty, especially concentrated poverty, develops its own cycle and it becomes very, very difficult to get out of that. So when we talk about the essential workers and frontline workers, Black and Latino workers are overrepresented in those industries. So they are more at risk of getting infected. And then they're more at risk of getting infected. And then when they come home, they're more likely to give it to their family because they live in what we call overcrowded households. Now, we're not talking about a skyscraper with 500 units in it. We're talking about a home where is defined as being overcrowded if there are more people living there than there are rooms, and that doesn't include the bathroom. So if you've got 8 people living in a 2-bedroom apartment, it's overcrowded and there's no way that you can quarantine. There's no way that you can socially distance, so that when you go to a job that exposes you to the virus, you then come home and you're exposing it to your family. And so what choice is there about, for an essential worker or someone on the front lines? Do they go to work and risk getting infected and bringing it home? Or do they stay home and then get evicted and become homeless and hungry? And people talk a lot about people need to make better choices and this and that, but sometimes there are no good choices on the list. And people end up living a life where they just tend to work towards surviving. And it's difficult to plan for next year or the next 3 years or what, when you're worried about next week. And it's not that people make poor decisions. People don't have a lot of good choices on their list to be able to make good decisions. And along with crowded households, there are multiple generations living in the same household, so that you've got people on both spectrum, very young family members and older family members who are at risk of, once they get infected, of having a bad outcome. And if we look at who gets sick and who dies from COVID, it's Black and African Americans who are impacted the most. Now, this data is from July, but the exact numbers may have changed, but the picture isn't any different. We're disproportionately affected. Latinx are disproportionately affected. Native Americans are disproportionately affected because of all of these other factors that place them at higher risk of getting infected and a higher likelihood of having serious illness. Now, what's happened with COVID? We don't test. We don't test well most places, but if you're wealthy, you find a way to get tested. If you have insurance, you find a way to get tested. But there's lack of COVID testing in minority and poor communities. They're more scarce. Drive-through means you have to have access to a car, which many poor people do not have. There are long waiting times to get the test done because the need is greater than what the resource has been provided, and you wait forever for results. And I just wanted to mention something about water, because we often don't think about the fact that not everybody in this country has access to water. You look at Flint, Michigan, who since I think it was 2000, or when the issue with all the water, that they still don't have clean water. And so you look at the Navajo Nation, 20% of the people who live in the Navajo reservation do not have access to water. A lot of people do not have plumbing. So when we talk about wash your hands frequently, we say it, but if we know that that a lot of people don't have access to do that, then we have to address that rather than just ignore it and then wonder why we have these inequities. And that's what's being done. And I didn't realize either that schools are not required by federal law to test drinking water for lead. Knowing what it does to children and knowing that poor communities often still have much housing with lead paint. So it's this whole concept of acknowledging that there needs to be more done for poor people and people of color is not being done here in this country. So you can't have a group that's disadvantaged without their group being that is advantaged. And that is exactly what's been done in this country. And one of the things that happens is that this social contract, if you work hard, if you follow the rules, if you do this and that, you will be successful. You will get the things you want. But the forces against that, racism, works almost invisibly and no one sees it. And segregation has a lot to do with that because if you're wealthier and white and you live in another community, you don't see the poor Black people. They build the expressways so you don't see them. So the urban planning, if you really look at it, it isolates poor people and people of color. And so this idea that somebody is disadvantaged becomes invisible because what you see when you are advantaged, you assume to be the norm. Just like the whole thing with race, that white is superior and Black is inferior, it becomes the norm because it's part of the fabric on which this country was built. And Frederick Douglass said, no republic is safe that tolerates a privileged class. And that's exactly what we have done here. And we are not safe. We are not safe by any means. And that it's to everyone's benefit that everyone has an equal chance because we all can have something to put in. I look at what all the inventions that Black people came up with, all the things that they developed after slavery ended for the next 20, 30, even now, all the things, those roots were in the plantations. And if you write off all the people in that plantation, those things never would have occurred. And just like you can't write off all the people in these poor communities because the roots there can help provide the things that everyone can benefit from. So I didn't want to go over time, but I think I made it. So that's my point, is that we have these inequities because they were created. It's nothing about being Black that makes you more likely to be poor other than the fact that you're a victim of a structurally racist society. But there's nothing innately about being poor or Black or any minority or people of color that gets you there. It's a system was made to put you there. So I'm done.
Thank you, Dr. Rogers. That was very enlightening and I think a great summary of our history that's important for us to move forward. And we will flow right into the presentation by Dr. Fuller. Please give her a moment to share her slides. Thank you.
All right, now I'm unmuted. Can you all hear me okay?
Yeah. Yes.
Okay, great. So first of all, I just want to thank you all for inviting me to come and speak. Thank you so much, Dr. Rogers, for that wealth of information. I was over here taking notes. I've learned quite a few little tidbits of history that I was unaware of. So thank you so much for that. And thank you, Touro University, for putting this series together. I want to start off by acknowledging the fact that we are under several layers of trauma right now with the pandemic, with the police brutality, with racism, with all of that. And we carry that and we bring that with us in our workspaces, in our everyday life. Even though we may look okay on the outside, a lot of us are having really deep emotions right now. And so I just wanted to acknowledge that and thank you all for showing up here today. And I'm hoping that through these conversations that we can start some healing, because it's through sharing the story and talking about these things that we are able to actually start the healing process, which we have not been able to do in a significant amount before. I also want to take some time to just acknowledge some of the people that we've lost through injustice, both nationally and locally, like George Floyd, Breonna Taylor, Willie McCoy, Sean Monterosa, Tamir Rice, Emmett Till, and the list goes on and on and on. And I want to say for Breonna Taylor is that even though the message that was sent was that your life was less than meaningful than your neighbor's wall, we know that you had great potential, and we know that you are very valuable, and that through this and through examining systemic racism, we're hoping that we can start dismantling this system. So the reason why I named this presentation Racism, the Other Pandemic, is because at some point, COVID-19 is we're going to have a vaccine coming out soon. Hopefully we'll have herd immunity coming out soon. And at some point, we're going to get back to a life. If it's not the norm like it was before, it's going to be back to a new norm for us. But what's going to continue is the effect of racism, and that COVID-19 has put a highlight on the things that were already there in existence, as Dr. Rogers has pointed out. So I want to start with this quotation. You can't separate peace from freedom, because no one can be at peace unless he has his freedom. So Black people, people of color, Latinx people, we all are resilient, and we've shown that, or we wouldn't be here making it as we are today. But my hope is that we can move from a place of resilience and move from a place where we're fighting for just the basic human rights to a place where we can actually have freedom and peace. So in the beginning, when COVID first started, it was named the Great Equalizer because it's a virus, and viruses typically affect everyone. But as mentioned, what it really did was put a highlight on different social determinants of health and structural racism that was already there. And in some cases, because we were sheltering in place and we were at home and watching the TV, it brought more attention to what was going on around us. And so we saw the last moments of George Floyd, and that sent out a big wave from locally throughout the country, and it got our attention. So anyways, the COVID-19, that was one thing that was good that came out of it, that it actually brought more attention to something that we already know was already happening. So in the next few slides, I'm just gonna briefly kind of highlight the overall theme of the social determinants of health. And then I'm going to go into specific data about what's happening in Solano County. So I put this slide because I want you to really understand that the system is not broken. A lot of people say, well, we just need to fix the system just needs to be tweaked, we need to work within the system. But the system is not broken because the system is designed for exactly the outcomes that we're getting. And I'll give you two examples of that. One being policing and the prison system. So shortly after slavery, policing became in effect because we had Black freedmen out, free. And so that's when policing started, was because you had now competition of resources. You had this construct of, white supremacy and oppression. And in order to keep that oppression going, there needed to be a system to, keep that establishment of oppression going. And so that's where policing actually was birthed out of. Policing neighborhoods was not a thing before that. And so we have to be mindful of that when we're looking at our police system today and knowing the roots of that and why we're seeing such things like mass incarceration and innocent victims being killed right in front of our faces. The second system I want to just touch upon is the healthcare system. So, we have a cycle of trauma, and we also have a cycle of trauma within the healthcare. So a lot of what I do is when I talk to women of color, especially Black women, what I hear from them when they're being counseled because their babies died before they turned 1 year old, or they had someone die in their family, is that they were not heard. They told their doctor something was wrong and they were not heard. And we see this go on through generations. If you look at James Marion Sims, the quote unquote godfather of OBGYN, he got his practices and his, perfected his techniques of operation by abusing and torturing Black slaves. Black slave women were not able to say no. Their cries were unheard. And he did not use anesthesia as he was perfecting his techniques. It got so bad to the point that the fellow white men who were helping him, hold down these women as he was operating on them without anesthesia. These white men could no longer stand to hear the cries of the Black women. And they said that they could not help Marion Sims with these procedures any longer. So what happened next was that he used other Black women to hold each other's down as he perfected his techniques. And we celebrated this man. There was a statue of him celebrating his accomplishments. But the dark side of history wasn't told. And unfortunately, that became a pattern of Black women not being heard and their cries not being listened to. So just a quick overview, and we're going to go through these in a little bit more detail. But Dr. Rogers did a great job of explaining how the factors that affect African Americans with COVID-19, why COVID-19 is having such a profound effect on especially Black people and Latinx communities. And so if you look at the CDC, they kind of put these into three different buckets: environmental inequities, wealth inequities, and underlying health conditions. All of these are interlocking and interrelated. And I hope when you listen to Dr. Rogers' presentation, you saw that, that environmental inequities, wealth, and underlying health conditions all overlap. But one thing that connects all of them is toxic stress. And in the next slides, I'm going to go over toxic stress just briefly, but kind of how the anatomy of what happens. That stress is bad for the body, but some communities, some people experience stress on a whole nother level. And when you have toxic stress, that does really big damage to the body. And then underneath, you see different examples for each of those buckets And I will go through like some specific data in Solano County to kind of explain how we got to where we are right now. So looking at toxic stress, we have the flight and fight response. And the flight or fight response in itself is something that's very needed. You know, it's a part of the body that you need in case, you know, there's a car coming, you need to jump out of the way. You know, we've all heard the analogy of like a bear about to attack you, and you need to be able to either fight or run. But when that response is overacted, then it causes trauma. Trauma can overact that response, and it becomes like a track in your brain in which you replay that trauma over and over again. And that response, that stress response, is overacted. So we have two pathways in our systems: the sympathetic pathway and the parasympathetic pathway. The sympathetic pathway is like the gas pedal. So when that's activated, your blood pressure increases, your heart rate increases, there's inflammation that's going on, your blood sugar increases, all of that. And again, in the short term, you need that. You need your airways to start breathing faster. You need your heart to start pumping faster, because again, you're either going to run or you're going to fight. The parasympathetic pathway does the opposite. It turns everything off. And so when these things are in balance, then you can, you know, turn it on when you need it and turn it off when you don't. But as you see, when the sympathetic is overacted, it can lead to chronic disease, and it can also make chronic diseases worse. So if your blood pressure is increasing and you're under a tremendous amount of stress and you have hypertension, it's just going to make it worse. Same thing with diabetes. Your blood sugar is increasing. If you're under a tremendous amount of stress, it's going to make it worse. And one thing I want to make clear is that racism is a form of trauma. And it's a form of trauma that has been passed on through generations. So these are some of the chronic diseases that have been linked with COVID-19, but also that are shown to be prevalent among Black Americans: asthma, heart conditions, obesity, diabetes. And again, I hope that you will start to see the link to the toxic stress as well as the social determinants of health when we're looking and talking about these diseases. So this is a quotation. Actually, it's a paraphrase from Dr. Ibram Kendi, and it's from his book, Stamped from the Beginning. If we truly believe that people are equal, then disparity in condition can only be the result of systemic discrimination. As Dr. Rogers pointed out, there is no difference in races. You know, genetically, biologically, we are the same. And so why are we seeing these disparities? You know, if we really truly believe that we're equal, then there's something else going on, and that's systemic racism. So the next few slides, I'm going to go and dive a little bit deeper in what's happening in Solano County. So one thing that I hear about Solano County is like how diverse we are, you know, and it's true. I'm not sure we're still the number one most diverse city in the or county in the country, but we're usually pretty high up there. The one thing that irritates me about that statement, though, is that it implies that because we are so diverse, that we don't have any disparities, or that we don't have any issues when it comes to systemic racism. You know, that's by some miracle, we just were to figure that out, and we just live, you know, happily together. But as you see in these next slides, that's not true. So when we go through these slides, a couple of things I want to point out is that the group that's on the left have the best health outcomes. The group on the right have the worst health outcomes. Solano County is coded in this kind of like lighter orange. And I also included California data just as comparison, and that's in the darker colored orange. So if we look at the first slide, which is the food desert, which is an environmental factor, we see that Asian Americans are doing well. They're on the left side of the graphic there. On the far right are Black and Pacific Islanders. So what this means is that low-income people that have access to food within a mile radius. So if you don't have access to food within a mile radius, then that means that you're living in a food desert. And it's so important to be able to have access to healthy foods and healthy vegetables. I mean, just on an everyday life, you know, to be able to eat healthy is going to help prevent diseases. And surely it's going to help with the chronic diseases. If you're talking about diabetes, and you're telling people that they need to eat healthy and their closest grocery store is over a mile away, and then compact that with that they don't have transportation, then how are they supposed to eat healthy? You know, could they grow fruits and vegetables in their yard? Well, that's if they have land and access to that, you know. So we have to really be mindful about this real issue here in Solano County. And, you know, how do we navigate this and make it so that healthy foods are available for everyone? I mean, that should be a basic right, you know, that you should have accessible, you know, clean, healthy eating. On the next slide, we're going to look a little bit at poverty. So I just want to kind of take us back even a little bit farther in history when we talk about the wealth gap and see how it, even though this is, you know, several hundred years ago, how it's still impacting us today. So as Dr. Rogers says, a lot of things that we get told is, you know, if you're Black, just pull yourself up by the bootstraps. And if I can do it, you can do it as well. But the one thing that is usually overlooked or completely ignored is how wealth was even generated in this country. So one thing I want to point out is that slavery was a business. It was a very lucrative business and produced millions, if not more, of wealth to whites. And this whole concept of race was developed because of slavery. You know, there was no white, Black before that. It was developed so that there was a system in place so that whites could have superiority and so that Blacks would be oppressed so that they can keep this industry going that was producing money. And so that they could keep, in order to keep that industry, they had to have some level of oppression. So for over 400 years, Blacks worked for free, and what they made went to white slaveholders, and not just white slaveholders, but white people in general benefited from slavery. So we're talking about 300, 400 years of that happening. Then after that, you know, we start seeing communities in the United States where Black people actually started to accumulate their own wealth and started having, you know, own banks, own schools, and was prospering. And you may be familiar with Rosewood and with Black Wall Street. So if you're familiar with these, then you know what happens in history. Back in the early 1920s, in both areas, Black Wall Street was in Oklahoma, Rosewood was in Florida, but in both areas, there was an allegation that a Black man either inappropriately flirted with a white woman or tried to rape a white woman. And what happened after that was complete destruction of these two areas where Blacks were affluent and were actually making, you know, money for themselves. And when I say destruction, I mean thousands of lives taken, thousands of people are now homeless because in Black Wall Street, there was bombs being dropped. There were people, white mobs going through the towns and killing people. And the police system did not come to the aid of the Blacks in that neighborhood. In fact, after this, the only people that were arrested were Black people. And there was supposed to be reparations, given. And if any were, it was very little, and it wasn't what was promised. And so you go again from slavery to now we're free and we're building some wealth, and then that gets destroyed. And now we're still trying to build and still trying to catch up. And again, as Dr. Rogers says, how is wealth being passed on in this country? It's usually through land, and it's passed on through generations. So if you're now like 500 years, 450 years behind the curve and not giving any reparations to catch up, then how are you expected to just pull yourself up by the bootstraps and, just get out there and do what I did, because it worked for me? That is unrealistic and it's not happening. And we can see that with this graph. If you look at this, Blacks in Solano County their rates are 3 times as high as whites of living in poverty. The next thing I wanted to look at is crime and justice and incarceration rates. And this, even though I know about mass incarceration and I know the history, it still was a little shocking for me when I looked at the actual rates here in Solano County, that Blacks are 8 times as likely as whites of being incarcerated right here in Solano County. And so, it just goes to show that even as diverse as we are, we're still getting the same outcomes because we're still living in the same systems of oppression. So the next slide I want to look at is life expectancy and give a little word on health and also on underlying health conditions. So if you saw in my previous slide, what I want to point out is that in healthcare, there is bias and there is systemic racism. And what we hear most often is, again, shifting blame and even shame to Black and Brown communities. And anytime there's data that shows, that Black and Brown communities have increased in chronic conditions or, poor outcomes in health, usually the response is, well, if you just took better care of your diabetes, then you wouldn't be in this predicament. If you just ate healthier, if you just listened to what the doctor told you, then you would be better. And then the other thing we hear is that Black people, in particularly, don't trust healthcare. But I would like to reframe that. And it's not that Black people necessarily don't trust healthcare, it's that there has been an abuse of trust in healthcare. And for example, we can start with J. Marion Sims, but we also can look at Tuskegee. And most of you are familiar with Tuskegee, this Tuskegee experiment. And most people think that that was like one incident at a time that happened and it was terrible and we have moved on for that. But unfortunately, that's not the only example of which trust was broken and abused by people in power and people in healthcare and even people in public health. You may or may not be familiar with the term Mississippi appendectomy. And that was something that was coined by Fannie Lou Hamer. And basically it's that when what was happening, especially in Mississippi, is that Black women were going into the doctor, we're going to have procedures, and then we're leaving out without a uterus, without any consent, and without knowing that that was going to happen. And this was so that medical students could get the practice and also to have sterilization of Black women. And so this stopped not in the early 1900s, it stopped in 1980, not that long ago. So again, we have to address these things that have happened in recent history and in past history, because there's cycles of patterns that happen. And it's not that, that Black people just don't trust healthcare and we just don't go into the doctor because we just don't trust them, even though us not trusting them is very validated. It's that there has been a gross abuse of trust from people that we should be able to trust. And I'll give you an example just personally. I'm a pediatrician. I have my mother who lives with me, and she has chronic illnesses, and she has Crohn's disease. Well, whenever she goes to the doctor, I make sure that I know what's happening and I advocate for her, because I know the system and I know, what's supposed to happen and what's not. I may not be an adult medicine doctor, but at least I have the general knowledge of the body. And I can tell you that advocating for my mom, even as being a MD behind my name, has been challenging at best. And I have witnessed the implicit bias and systemic racism. And I think to myself, with my knowledge, I'm having, difficulties getting the help that I need from my own mother. I can only imagine people who don't have that knowledge or who don't speak the language or speak English, what kind of obstacles and problems that they're having. So there is a need in healthcare. We need to address the systemic racism, and we need to address the implicit bias. And if you look at this graph, you will see the expected life expectancy broken out by race. And it's no different than pretty much the national average. Is at least 3 years, if not more, less. The Black life expectancy is lower than whites, and is the same here in Solano County. One other thing I wanted to show was this graph, and this is the life expectancy by zip code. So we see here that the lowest life expectancy is in South or Central Vallejo, whereas the highest life expectancy is in Davis and Dixon. If I were to show demographics of race in these areas and laid it on top of this graph, you would see that the highest proportion of Blacks would be in Vallejo, and that Davis-Dixon would have a higher percentage of whites. And then if I also took a look at education and school systems and zoning or redlining, you are more than likely to see the same thing. So let's talk about education. This quotation, again, by Dr. Kendi, goes, "There could be no more consequential white privilege than life itself." So I was asked once, after giving a statement, that, "Doctor, do you really think that equity is the answer? And shouldn't we be looking at education and not equity?" So, taking the question at face value, let's look at education. And before I go into these graphs, I want to say that I come from a family of educators. My mom was an educator, and I actually did work in the school system sometime many, many years ago. And I know how difficult it is to teach and to be a teacher. These graphs are not looking at intent. What they're looking at and what they're examining is impact. And when we look at this, we see two sides. On the left side is the third grader scoring proficiency. And again, on the left side of the graph are the races that are doing the best, and on the right side are the ones that aren't. And we see that Latino and Black are on the right side. Then, even a little more shocking to me was when I look at the percentage of suspensions. And we see that Filipino, Asian, and white are on the left, and Pacific Islander, but mostly Black is on the right. And so it comes back to that quotation by Kendi earlier. You know, we could look at this graph and say, okay, well, maybe Black children just don't learn, and maybe that they are just more violent than others, and that is the explanation for why we're seeing these gaps. But if we really believe that people are equal, and we know that to be true, which it is, then there must be some other explanation for this. And we have to look at our education systems and see what is causing these big gaps in education and also in suspension. So one other thing that kind of stuck out to me was that the suspension graph looked quite similar to the incarceration graph, and that the Blacks were not just higher, but higher by a significant degree than other races in the number of children who were suspended, just as the number of Blacks who were incarcerated. One last point about this slide is that education is a factor for life expectancy. So, you know, it kind of strengthens the point about the previous slide of Blacks are having a lower life expectancy, especially if we're seeing things like this that's happening in our education systems. So the last slide I wanted to show is, the last slide of data I wanted to show is the COVID death rate in Solano County. Now, after sitting here for the last hour or so and looking through all of this data, both nationally and locally, it may not be a surprise, it may be a disappointment, but not a surprise to see that Black and African Americans are dying at twice the rate of whites in Solano County, followed by Asians. And the death rate, even though the rates of, you know, how many people are actually infected may be skewed because of our issues with testing, the death rate is something that comes from death reports in hospitals. And so that is even more accurate. So what do we do about this? And I like to use the this song, and bear with me, you may be familiar. It's a kind of like a folky song. It goes like, there's a hole in my bucket, Eliza, Eliza, there's a hole in my bucket. And basically what the song is saying is that there's a man who has a bucket with a lot of holes in it. And he keeps bringing it to his wife, Eliza, and telling her the problem, that there's a hole in his bucket. And Eliza keeps telling him how to fix it. And he keeps telling her that that's not going to work. And the reason why I like this song, because this is kind of what happens, a good analogy for what happens, you know, with this, especially when we're talking about race today, is that instead of starting somewhere, whenever there's a solution or a potential solution that's being presented, we usually say, oh no, that's not going to work, you know, and we're not going to do it. And if we look at this, you know, you can look at it different ways. So there are those who say, you know, it's just not going to work. And then there are those who say, well, let's just put one finger in one hole and ignore everything else. And then there are those who ignore the entire bucket and just keep filling it with water and going about the day. And so what we need to do is address this, and the holes are symbolic to systemic racism and all of the social determinants of health that attribute to, you know, the poor health outcomes that we're seeing. So it's not going to be useful to just put a finger in one hole and just talk about education if we're not going to talk about systemic racism. You know, we could talk about education, but if we're not going to talk about why we're seeing what we're seeing and, you know, the root causes of it, then it's not going to fix the problem. And then, you know, the worst thing is to ignore it completely and just keep filling it with water. So These organizations have publicly announced that racism is a public health crisis, and public health is something that reaches everything. You know, it touches buckets. It doesn't matter where you're working. If you're not actively involved in public health, you know, the health of a community reaches many, many different facets of a population. And I think that COVID-19 has been highlighting how vast public health is. So that racism is a public health crisis is something that we all need to pay attention to and prioritize. So some steps in the right direction. GARE, the Government Aid Alliance for Racial Equity, uses this framework of normalize, organize, and operationalize as a way to approach racism and systemic racism and to, you know, make change. We must shift from a reactionary response to prevention. And we have to have anti-racist ideas, policies, and systems. There is no neutrality in this, and when we're talking in this in general. You know, you can't sit in the middle because racism is like a moving train. So either you are going against it or you're on it and just moving along with it. So unfortunately, you can't be neutral. But fortunately, you can be anti-racist. We need to hold people accountable, and we also need to act now. You know, we've waited too long, people are dying, and we need to not be like that, you know, the song Eliza with the bucket, and just say, oh no, it's not gonna work, it's not gonna work. We need to start looking to our communities. I really believe that our communities have the answer and have been telling us the answer, but instead of partnering with them, unfortunately, a lot of times we create more barriers. And so we need to decrease the barriers, and now is the time to put into action. So where do you fit in all of this? You fit, again, by being anti-racist. You fit by letting your voice be heard. And you fit in, this is election time, you know, the debates, the vice president debates was just last night. And so this is the time to get out and vote, get involved. I'll do a shameless plug for Solano Hills, which is the health equity for all for Blacks and African-American lives in Solano. Is a community group which works to help decrease infant mortality, Black infant mortality, because Black infants are dying at twice the rate as white infants. And so that's one where you can get involved in, but there are many that you can get involved in. Whether you're a student or just a community member, there's many opportunities for you to act and to be involved. So again, there comes a time when silence is betrayal, and that now is the time to act, and now is the time to be involved. And I'll end with this slide. We need more light about each other. Light creates understanding. Understanding creates love. Love creates patience, and patience creates unity. Thank you.
Thank you so much, Dr. Fuller. We really appreciate your talk and really highlighting all of the social inequities in Solano County and steps that we can take to improve the inequities in our county. We're going to now open up the Q&A section and begin asking our panelists questions. And if you would please populate the Q&A function with your questions to the panelists. That way we can have a running log of the questions. So please use that function now.
While our attendees are formulating their questions, I just want to first thank both Dr. Fuller and Dr. Rogers for a really such a comprehensive historical perspective, which I think is so significant, so important, as you both eloquently kind of, take us through the journey of understanding that, genetics is not the cause of health issues in this country. You all are both physicians, you are clinicians, and so you work with patients on a one-on-one basis. Have you been promoting or heard of the idea of providing this historical perspective? I mean, I know a lot of medical education is now beginning to look at social determinants, but going back in terms of the root causes of why we have these inequities, as you all both beautifully present. Have you heard about medical education looking at ways to encourage that in medical education? That's important beyond measure.
Yeah, so like you mentioned, like when I was in medical school, which I'm not going to say how long that was ago, but not that long ago, we didn't talk about well, in medical school, we talked about it because I went to a historically Black college for medical school, but in residency, we did not talk about it at all. And now I think we are starting to see the turn. And there are some places, some states that are requiring like implicit bias training for medical providers. And there are people who are working on like what that would look like and how to infuse that into the curriculum for medical schools. So I think it's just now starting to turn. I'm not sure if Dr. Rogers has more information about that, but I'm starting to see that more now.
Yeah, one of the things that's happening, there is a lot of bias in medicine, and I think a lot of it is because people have no idea why these inequities are here because they don't know the history. But one of the things that is actually quite, I don't even know how to describe it, but if you look at some of the lab tests that we do, they have different calculations based on race. Like if you get a blood test to test your kidneys, and they call it the glomerular filtration rate, which just talks how good your kidneys function, how the blood goes through. And you get the blood drawn, it goes into the machine, and then it gives you a result. And there's two equations they use, one to calculate your function if you're white, and one to calculate your function if you're Black. Now, the basis for that has to do with this idea that Blacks are more muscular because the blood test depends upon your muscle breakdown and turnover. Now, where did that come from? No one knows. No one can figure that out, but that's been the standard for years. And what that does is it calculates a better kidney function for the same blood test because they use a different equation. So what does that do? Number one, it keeps Blacks off the transplant list longer. And then they have to wait so long for a transplant, and being Black, it's more difficult to get if you don't get a cadaver match, but it's more difficult to get a match. And you already have to wait. So things like that, lung function tests, they based it on this idea that started back in the early 1800s that Blacks had low lung function, and that's why they needed to be slaves and do hard labor so that it would make them breathe more and then get more blood to the brain because they didn't have enough blood going to the brain. And that's persisted into the equation that determines your lung function. So these things have persisted. There's others too, but they persisted for years. And now I know I'm on the faculty at Rush. They have now just eliminated that kidney equation. So there's one test, one equation now, and there's more and more hospitals doing that. But there has to be, from these national societies, the American Academy of Pediatrics, American Academy of Internal Medicine, all of these national societies, these groups of physicians have to take ownership of this and say that this needs to change, because this is the invisible bias in medicine that, people don't even realize it's there. They don't think about it. it's quite easy based on the way this society presents minorities and Blacks to believe that there is something different about those people, so that it's, it's easy to continue with this and not even think about it. That's the invisibility of racism, is that you see it, but you don't see it. Because I remember when I talk too much, but anyway, when I was a medical student, and he was actually the first Black resident I ever had, and I was doing my sub-internship. He said, Susan, the eyes won't see what the mind doesn't know. Mm-hmm. And I have repeated that a million times. And if you won't see the bias because you don't know it. You just assume they're different. So there is no bias here. But unless we teach people why there's bias and that it is there, they'll never see it. So it's a lot of education on a lot of levels. And doctors may be smart, but they're not smart about everything because there's still a whole lot of bias.
Thank you, Dr. Rogers. We have a few questions. And what I will do is I will read off the questions. There's one in the chat and the others are in the Q&A. So the first is to Dr. Fuller. It says that you mentioned the practical actions that can be taken, being anti-racist, let our voices be heard, and to vote. And it says, as a future clinician, how do you think the public health and social justice work in your clinic visits with patients affects your work with your patients, and do you respond case by case?
How does this affect my work? Was that the question? I'm sorry.
Yeah, so as a future clinician myself, how do you do the public health and social work in your clinic? Okay. Visits with patients. So how does it translate in your work with your patients? And do you kind of adjust how you respond case by case to each patient?
Well, again, we got to see people for who they are and, treat them as individuals. And one thing that happened when I was in training was that, and then I'm not sure if this is still going on, but when you present a patient, you usually present a patient, or you're taught to present a patient by saying, this is a 30-year-old African-American female that comes in with asthma, right? And so by saying that, what is the point of saying African-American female if it has anything to do with why they're here to be seen? And by doing that, you're already setting the stage for our own implicit bias. One thing about bias is everyone has bias, okay? Everyone has bias. You can't go through life without having bias. And the thing about it is that you have to address the biases that you have. So one thing that I do is that if there's anything that's coming up for me that's kind of like a knee-jerk reaction, or I'm feeling uncomfortable, or feeling, that I'm, acting out of my own bias, is that I take a pause and I reassess the situation. One thing that medical students can do is take the IAT, which is the implicit, I'm forgetting what it stands for, but it's an implicit bias test that Harvard sent out and that you can find it online. And that is the first starting place that I would say to go in. And there's different categories from race to gender to all sorts of things that you can look at. But you have to be honest with yourself about that before you can even, start to think about, implementing equity and things like that. The next thing that we're doing here locally is that we are doing some trainings on anti-racism and implicit bias. But what I want to say about that is that a training in itself is not going to be the issue, or it's not going to solve the issue. That you have to start with a training, because the training starts with normalizing the conversation. And then it opens up that dialogue most people find it very, very difficult to talk about race, especially if you are not Black. Usually people of color are forced to talk about race at a very early age. But if you're white, you're not really forced to look at your whiteness. So it's very difficult to have conversations on race. So when you're doing these trainings, you're normalizing the conversation, and then you have to look at your systems and your practices and see where there is, not if there is, but where there is, any kind of bias or racism in your system. We know that they're there. So you have to examine them where they are and then do something that has longevity. You're going to be a lifetime learner of this. It's not a one and done. Okay, now I've addressed my biases and I'm not racist and I'm good to go. No, it's a long time, lifetime process, and it's a continual process that you have to continue to do. So that's what we're starting to do here in the county, and that's what I would suggest for all the students.
Thank you for that. The next question comes from one of our joint PA-MPH students who wants to thank both of you for your presentations today. She's asking, how do you begin to explain systemic racism and the physical manifestations of subsequent toxic stress to your patients? She's wondering how to transition this conversation from an academic setting to one to provide to her future patients.
Question, no. I mean, it's difficult because we all experience it on different levels. There was, when I went to medical school, and I'll say I was a freshman in 1975, and I had no idea that the AMA was segregated until, it didn't desegregate until 10 years before that. So all these old white men that were teaching me had grown up in a segregated medical practice. They maybe saw patients, but it was, they didn't want me to be there. They didn't think I deserved to be there. But that bias towards me was also towards the patients they saw. And so it's the same, we see it. And that's why the bias continues, because they haven't learned anything different. Just because they're doctors doesn't mean, and it's the same thing with the police. The police, as boys and, girls, grew up listening at the kitchen table to their parents talking, and the same, just like the police that, started after Reconstruction. They came from the slave patrols. They were there to criminalize Black behavior, no matter how benign it was. So it is so entrenched in our structure and in people's behavior that we need to just learn to call it out. And it's difficult for students. Medical students ask me this all the time because they're in a difficult situation. They need a letter of recommendation. They need an evaluation, and so they don't want to do something that's going to interfere with that, yet they feel compelled to protect the patient that they may be taking care of. It's so intertwined, and the bias that's there. But I saw a question too, someone asking how can they do these hysterectomies? Because structural racism is based on devaluing a lot of people. And so doing a hysterectomy on a woman that you see no value in is not difficult. And that's why this perpetuates, this devaluation of people is, part of the structural racism. And, but we just need, as attendings, I feel, and even as a resident, I felt more comfortable calling it out when I saw it. We have to be loud.
Thank you, Dr. Rogers. There is another question with regards to further reading and education on these issues. I saw in the chat that Medical Apartheid. Dr. Rogers, you listed that, which is a fabulous book. But if there is anything else, our students are currently reading The Death Gap by Dr. David Ansel. But if you have any other suggestions for reading, that was one of the questions.
I would say White Fragility by, what's her name? Robin DiAngelo. How to Be an Anti-Racist by Ibram Kendi. There's some documentaries on Netflix, if you are a Netflix person. 13th, I think it's called, is a good one. Yeah.
PBS has a documentary. I think you may have to buy it now, but Slavery by Another Name, that talks about the convict leasing and all of that happened. I know that I haven't read it yet, but Isabel Wilkerson wrote The Cast. She wrote More Than Other Sons that talks about the, yeah, I haven't read that yet, but is it good? Everybody raves about it.
I'm about halfway through. It's amazing. Looking at racism as a caste system, which is something I had never considered, and looking, comparing it to India's caste system. So it's a remarkable look, and also connecting the dots with Nazi Germany. So it's a really interesting journey across how we came to this place of being really more of a caste system than almost India.
Yeah. And there's a lot of magazine articles. The Atlantic I like, and they have a lot of articles that address issues like this. I find that easier because it's a shorter read than to do a book, than to commit to a book. I find it easier but that's just, maybe I'm getting lazy in my old age, but.
There's one last question. I'll go ahead, Gail.
No, go ahead.
A minute.
Okay, let's see. What is the best way to encourage communities of color to vote when, as Dr. Rogers laid out for us today, the American government has repeatedly failed and harmed people of color? It's a tough one.
There's a lot of organizations out there that work on that. I mean, even now, there's an opportunity, to work the polls. I know that I early vote. We can early vote in Chicago, so it leaves me free on election day. And I can hook up with a senior home and drive them to the polls and just spend the day doing that, but we just need to, I think a lot of people, one of the things we need to do too is to address this thing about how felons can't vote. And like in Florida, I'm not sure what's going to happen now that Bloomberg gave them all that money and whether they're going to allow them to vote or not. Because what I read too about that was that a lot of the felons themselves had difficulty finding out how much they owed, because it could have been a small enough amount that they may have been able to take care of it, but they work in slow motion. So there's all these things, people try to do the right thing and then they just get blocked. And so the government wasn't helpful in trying to help them resolve that issue. So there's a lot of voter organizations, poll watcher groups and all to get involved with, but we need to become a socially active, a social activist that gets out there and, works the pavement and talk to people. These lectures are fine. Don't get me wrong. I think these are great because we need to do these, but we're speaking to a group that's already enlightened to some extent, because otherwise they would not have joined this webinar or this panel. I'm not sure what the words are now for these things, Zoom. But, we still need to get in the streets. And we still, I know with COVID and all, but, even though I'm in a high risk group, I get there with my mask. I try to social distance because I look at it that, I have 2 grandsons. And so these Black boys, I can do by me trying to make sure that they can get through life and still live is more important than whatever I can materially do or whatever for them, So it's worth it to me to take that risk to go out and be involved marching and stuff.
Yeah, I mean, I agree. I think a lot of positive peer pressure helps. I know people who never voted in their life, and then like the first time they voted was like when Barack Obama was elected, and it was because so many people were just organizing. It was just like really getting the word out, and we're taking friends with them to the election polls, and registering to vote, early, and thinking outside the box. I think now with everything that's going on, and we're more isolated, it's a little harder to do, but I think you just have to get more creative, and there's a lot more on social media and places like that where, you can share the link of how to register to vote, and this is where, this is how to vote, and just keep talking about it. I think the more that we talk about it and more that we address the need for it, then the more, it just gets it out there, and then people start to come around. But just don't stop talking about it, and don't just assume, that things are going to go your way because your neighbor is voting for what you want. You have to, every vote has to count. So, and just keep spreading that message.
Yeah, thank you so much. I think we have time for one last question, and I just want to point out in the chat there are a number of additional readings and textbooks that people are providing recommendations for. So if you want to take a look at the chat. And then I believe our last question here is many times general health statistics are based on clinical research, but sometimes the participant makeup does not properly represent or match the demographic of a certain community. What do you both recommend to help with recruitment of minorities such as Black and Latinx people, taking into consideration the mistrust in clinical research, understandably? Study findings sometimes highlight disparities or in some cases offer helpful opportunities that would not otherwise be offered to them. And I guess either of you can take it, or both of you.
Well, if we talk about like clinical guidelines that, you're supposed to do this for this symptom and this for that disease, and we have these clinical guidelines that are based on research studies that mostly do involve white people. And there's a big problem with that, I agree. And interestingly, there was a drug that was used for heart failure that it was a study done to prove that it worked better in Blacks. And so there were only Black people in the study. And so it got approved by the FDA and marketed. And now the whole motivation for this was based on money. But the thing about that was that why is it that you have all these other studies with mostly white people and you apply the results to be used with everybody? But here you have a study with Black people, but it's only for Black people. We can't extrapolate those results to white patients, but we do the reverse. And so that in itself, this is why the medical community is biased. The bias is in there too. And the other thing too is studies take time. They take a lot of time commitment from patients. You have to go, you have to maybe get blood work, you have to go back for periodic tests. And the way a lot of people live, they don't have the time to do that. And the amount of money that they pay you isn't necessarily going to make or break you. It's not enough for you to make the sacrifices that you may have to make. And so there's just a societal, deterrent for people to commit themselves to something that they're not really sure they're going to get any benefit from. Why should I help these white people figure this out? And so there's that reluctance, which I totally understand. I mean, that's, you know, I won't say that's my reaction, but that's, you know, how a lot of people respond. What's in it for me? And the $25 or $50 for the visit isn't enough to make it worth, you know, it may be, but there's just been a reluctance for Black people to help the medical community because as we've, you know, we've said, Shandi showed it clearly, you know, the abuse, they abuse the trust. And that's going to be a difficult hurdle.
Are you either of you knowledgeable about what the percentages of people of color participating in any of the clinical trials for the COVID vaccine or any of the COVID vaccines?
I have no idea.
I don't know, but I was just going to add that, you know, trust is something that you have to build, but first you have to acknowledge that something was done wrong, you know, and I think that we just go about life and we just go about life. And, you know, it wasn't until just recently that when we look at health inequities, that we are starting to look at them from a racial lens. You know, I remember sitting in meetings just like a couple of years ago, and we see these big gaps, you know, over and over and over again, where Blacks are doing the worst. And it's just like, next slide. And, oh, we don't know why this is. Oh, and the implication is that there's something genetically inferior, you know, that's the implication. And so, you know, nothing's going to change if nothing changes. So we really have to dive deep. And if we're going to get, you know, these changes in how we do research and, you know, build trust and things like that, we need people in position of power that are people of color, you know, that are there, you know, able to make decisions, able to, you know, guide the research, and able to take that on, you know. And then we also have to make some atonement for what has happened. You know, we just go about our business and say, okay, yeah, all these atrocities have happened. You may get a sorry, you may not, but there's no atonement for that. And, you know, how do we expect Black people to just be like, okay, well, sign me up for the next thing, you know, when nothing really has significantly changed? So you have to start somewhere in that, in starting with the conversation and then changing the actual structure of it. Again, it's about like dismantling the structure and starting again.
You know, one of the things too that has been there, you know, there's been, you know, work to get the kidney test done so that race isn't a part of it. But there's other algorithms that physicians follow that still race is used as a criteria. And it's been shown that race actually causes more, it denies appropriate care more often for Black patients. So why is that even in there? I mean, why don't you put white as the thing, right? Why do you put Black? You know, that whole, again, it's the bias. It's become, that's the problem. The bias has become normal. We don't even question that there's an additional factor for Black patients. That's sort of the normal now, but we should really, why is that? You know, there's no extra Asian, there's no Native American, there's no Latinx. So it's, you know, it's pervasive and it's invisible, and that's why it continues. And so that's one of the things that we have to remove, and we have to get across that there is nothing genetically different about Black people that make them respond to a treatment or something else. If there's a different response, it's some social issue or some, you know, life issue. It's nothing genetic. It's not part of the person that makes the difference. It's part of the environment in which that person lives. that makes the difference.
Can I just bring up an example to kind of, to your point, Dr. Rogers? So I mentioned that my mom has Crohn's disease. And so my mom, grew up in the 60s. It was probably late 60s is when she started having symptoms, and when she was like a teenager. And so for years, she would go to the doctor, describe her symptoms. They didn't know what was wrong with her. They would send her back home. So finally, she actually saw, it was a resident, and he was like, oh, I think there's something else going on here. I think you might have, at the time, they thought it was ulcerative colitis. So IBD disease, typically you think of white American, having that. So when she went in to see the specialist said when he saw her, he nearly fell out his seat and couldn't believe that there was this Black woman in front of him being referred to for, ulcerative colitis. And what ended up happening was that she was being treated for something that she didn't have. She actually had Crohn's, which is even more, not what you think of. You don't, especially back then, they weren't thinking of Black people having Crohn's disease. So she was treated for about 20, 30 years for the wrong disease and treated with the wrong medications. And it wasn't until just recently that she got the right diagnosis and the right medication. But now it's, almost the damage is done. But again, if you don't, like Dr. Rogers is saying, if you don't think about it, you're not going to diagnose it. And because of the color of her skin, for a long time, she wasn't diagnosed with anything. And then, then she was misdiagnosed. And it was just because they did not think that a Black person could have ulcerative colitis or Crohn's disease. So, it's a real issue. It's something that you definitely have to, it's like the elephant in the room when it comes to healthcare. It's something that people don't even believe that racism in healthcare exists. So to even get that door open, that yes, it exists. And yes, practitioners are biased. And yes, we have to address that bias, but we first have to acknowledge that it exists and that it's actually causing harm to people, instead of helping people.
Thank you, Dr. Fuller and Dr. Rogers. We really appreciate not only an overview of the historical perspective, but also the steps that we can take as individual citizens, as patients, and then as future clinicians. And I think that even some of this, I didn't realize. I'm not a clinician, so I had no idea that a lot of these biases were built into how doctors are diagnosing patients. So I think there are quite a few ways that our students and public health practitioners can take action to make change. And with that, we're going to close our webinar for today, and we hope to welcome you all back for our next session. And our next session will be October 22nd. It's also a Thursday at 4 p.m., where we will address the determinants of criminal injustice. And we'll hear Dr. Ruben Miller address this issue. So again, we really appreciate you all coming and the great wisdom that Dr. Rogers and Dr. Fuller were able to impart to us today. And thank you for attending.
Thank you. I really enjoyed this.
Yes, thank you.
Have a great evening.
Good night.